Hello, everyone. Thank you for joining in today's webinar. Today, I'll be talking about acquired esotropia and what we know about this entity in 2023. I have no financial disclosures. In this webinar, I will be covering about pathogenesis of various types of acquired esotropia, how we clinically evaluate such a case when it comes, and what are the different management options for this particular condition. Let's start with a question for the audience. Which of the following do you think can be a cause of acute acquired committed esotropia? Can it be uncorrected myopia, uncorrected hypermetropia, prolonged patching, or all of the above? So a lot of you think that it can be all of the above. So that's great. The answer to this particular question is all of the above. And let's see now actually why this particular answer is correct. Before we start, let's understand what acquired esotropia is. So acquired esotropia may be acquired committant esotropia or acquired incommittent esotropia. Acquired committant esotropia has been divided into various categories. What was initially known about this particular entity called acute acquired committant esotropia was that it was mainly of three types. This was what was initially thought. One was the Swan type or type 1. The second was type 2 or idiopathic type. And the third was type 3 or the Bielschowsky type. Subsequently, further entities were added to this particular condition of acquired committant esotropia, the others being acute accommodative esotropia, decompensated foria, a neurological type of acute acquired esotropia, cyclic type, and one type which involved excessive near work, which is one of the recent additions to this entity. So what constitutes acute acquired esotropia? It has to be a condition where the onset is after 6 months of age. Anything where the onset is below 6 months of age will probably come under infantile esotropia category, but anything beyond 6 months of age will come into the acquired type. There should not be any lateral incomitance, and it should be an acute presentation. What acute acquired committant esotropia does not involve is these few types. Refractive accommodative type or partially accommodative esotropia, where the onset is known to be more gradual. It also does not include accommodative spasm, where there is associated meiosis and maybe myopic refraction. It does not involve incommittent types like acquired sixth nerve palsy or raised intracranial pressure or myasthenia gravis. Now, these last three entities may simulate a committant type unless clearly evaluated. So it is important for us to differentiate this from the committant type. But when we look at this entity of acute acquired committant esotropia, how frequently do we see it in our clinics? So one of the studies which studied the largest number of such conditions was the one that done by Seth et al., where they said that approximately around 4.9% of all childhood esotropias in a hospital setting would be acute acquired committant esotropia. Out of this, 3.3% of children were found to be less than 10 years of age. Now, if we compare this with the rest of esotropias, almost 37% of children less than 10 years of age presenting to the clinic would be infantile esotropia. So you can understand that it's a very rare entity. Probably only 1/10 of infantile esotropia would be acute acquired committant esotropia. There have been some other studies which have shown that the incidence is slightly higher, maybe around 14 to 16%. So we know what maybe it does not include. So let's look into what it does include actually. So this is a case, a dear-old male child had come to the clinic. He was seen elsewhere, and there was a slight disparity in the vision that was noted. Right eye had slightly better vision than the left eye for this child. And the child was advised long hours of patching, actually. And the parents were doing a random type of patching. Sometimes they're patching the right eye, sometimes the left eye. So, and the patch was left on for almost an entire day. So after starting of this patching, the child was brought maybe about 2 weeks after starting the patching to our clinic. And this was what we noted in the child. There was a large angle esotropia that was seen. So this constitutes the first type of acute acquired committant esotropia, which is also known as Swan type. Now, this type is precipitated by monocular occlusion. And what happens here is that there is an artificial disruption of fusion. So the most common cause here would be patching, which is a common form of therapy given for amblyopia. So when there is prolonged patching, sometimes there can be patching that may be done for a corneal abrasion, or there may be a mechanical ptosis for a period of 1 or 2 weeks when there is trauma in the child. So it can be any form of artificial disruption of fusion that can happen to the child, and the child will actually come up with esotropia. Now, we know that not every child that undergoes patching or has has to have the patch on because of a corneal abrasion actually comes up with esotropia. So what is the mechanism here? Why only some children come up with acute acquired esotropia? And the answer is in this particular slide, where you see that there has to be a latent convergent tendency in that child. So basically, there is a very slim reserve of fusional moments. So there is a tendency towards excessive convergence in such a child. And when there is an artificial disruption of fusion in them because of patching or because of mechanical ptosis, then the fusional reserve is not enough for the child to get back its divergence, and it goes into a constant state of convergence. So that is what happens in this particular type of esotropia. Now let's look at another case. This was a 4-year-old female child that presented with a sudden inward deviation since about 1 week. The only significant history that the child's mother was giving was that the child had been suffering with viral illness and had even been hospitalized for the same some time ago. And 4 days after recovery, the child started developing this kind of a condition. If you see, vision is normal for age. There is a very insignificant refractive error in the child. So this particular entity constitutes our type 2 of acute acquired committant esotropia, which is known as Franceschetti type. Now, this type presents with minimal refractive error, something that is very insignificant. It presents with a non-accommodative component, but mainly there is precipitation of squint without an artificial disruption of fusion, which we saw in the first type. There is no artificial disruption of fusion here. But what happens is just naturally, because of maybe stress, because of a viral infection when the body is under stress, or there is a rigorous physical activity or a minor head trauma, or sometimes if the child has a lot of psychological stress, then there can be an artificial disruption of fusion. Here again, there's very poor fusional divergence, very slim fusional reserves. So the child has been trying to fuse, but any condition that stresses the child and has caused a disruption of fusion has destroyed the fusional reserve. Now the child cannot diverge and therefore goes into a state of constant convergence. So this type is known as idiopathic type because there is no particular factor or there is no clear causal factor in this child. What we see in our clinics is very commonly this particular kind of condition. It's quite common. Now let's see another type. So this was a 6-year-old female child that presented with inward deviation since 1 month. The significant history here was that the child was an extensive reader. She used to read books for almost about 6 hours a day, but has never used glasses previously. If you can see, visual acuity for distance was quite poor. For near, it was still good. There was a very significant refractive error. She was a high myope, close to almost -6 diopters per in both eyes after cycloplegic refraction. But stereo acuity for near was maintained. She was having good vision for near as well. So if you see, the previous cases did not have any significant refractive error, but the third type actually has a significant refractive error, and this refractive error is high myopia. So this constitutes the third type of acute acquired committant esotropia, which is also known as Bielschowsky type. The pathogenesis behind this type is actually very interesting. What was thought to be the triggering factor in this type was that it was an uncorrected myopia and there was prolonged near work. So we all know that myopes are more comfortable for near. So when a child is myopic, they cannot see distance well, especially if they are uncorrected. So they prefer doing more near work and they start doing more prolonged near work with time. So they start focusing for near more, and subsequently what happens is that the near triad kicks in. So there is convergence, there is meiosis, and there is accommodation. For near, the child would still be orthotropic, but because of that persistent convergence, it is thought that it increases the tone of the medial recti in both eyes, and therefore the child goes into a state of constant convergence. But initially, for near, the child would be ortho, and for distance, when the child would have to use the divergent forces, the child would not be able to because of that persistent convergence and the increased tone of medial recti. So initially, manifestation would be a small amount of ESO deviation because of the convergence for distance. For near, the child would still be orthotropic in most cases, but subsequently with time, when the tone of the medial recti continues to increase, then it will result in a state of constant esotropia for distance as well as for near. Now, this condition is reportedly seen more in older children, and definitely they also have a decreased fusional divergence. Now, this particular entity, which was noted initially in uncorrected myopia, is quite significant, the pathogenesis, because it again comes into the picture when we are talking about excessive near work, which is a very recent type of esotropia that we are seeing in the clinics, that which is involving excessive electronic devices, more smartphones, but the principle is almost the same. Let's look at another case. Now, this is a 3-year-old female child, complained of inward deviation noted since just 10 days. At presentation, she had an esotropia of almost 35 prism diopters. Her visual acuity was slightly lesser. Cycloplegic refraction revealed a significant amount of hypermetropia. She was started on glasses, and after 3 months, if you can see, she's still wearing her glasses, but she still has a significant amount of esotropia. Now, this condition is an additional condition known as acute accommodative type of esotropia. This is different from type 2 because here there is significant refractive error of at least more than +3 diopters. There is an accommodative component that is present, but again, this condition presents quite acutely, mainly because of maybe poor fusional divergence, maybe because of increased stress. These are the factors that have been stipulated for this. So again, the near triad coming into the picture, there is overconvergence because the child wants to accommodate because of the high hypermetropia, and also maybe there is a disparity in the AC by A ratio. So all these factors come into the picture, and the child will have an acute presentation of esotropia. Now, we all know that this particular mechanism also works in what we commonly see in the clinics known as refractive accommodative esotropia or partially accommodative esotropia. So let me just ask you how you think an acute accommodative esotropia is different from a refractive accommodative esotropia. So which of the following is true regarding acute accommodative committant esotropia? Is it that In acute accommodative, there's a longer period of intermittent deviation. Maybe they present with asthenopic symptoms rather than diplopia. Maybe there's a larger angle of deviation, or they present with amblyopia and poor binocular vision. Okay. Okay, so it looks like there's a lot of confusion here. So maybe it's not so clear as to how an acute accommodative esotropia is different from a refractive accommodative esotropia. All right, let me then explain this further. It's actually a larger angle of deviation. So let me show you the slide, which compares the most common features of acute accommodative esotropia with refractive accommodative esotropia. Now, keep in mind, these are features, clinical features, which we most commonly or usually see with each condition, but this is not a rule. It's most often that we see an acute accommodative esotropia having a very sudden onset. That is why it is categorized as acute accommodative. Usually they present with a constant deviation with a large angle of deviation. As I said, the theory behind this is that there is poor fusional reserve. So once that reserve disappears, then there is a large angle, there's a constant angle. And because there is a sudden onset, they more often present with diplopia. But because it is just a short period of onset, usually binocularity is preserved. So in comparison, if we see a refractive accommodative esotropia, we see that there is a more gradual onset, and the esotropia is noted more intermittently. What happens is it is noted only when the child tries to accommodate. So when the child is trying to read or do more of near activity, that's when the intermittent deviation will kick in. It starts with a smaller angle of deviation and subsequently builds up. And what is quite significant in this particular condition is that very often parents will say that there is a variable angle. They will say sometimes the esotropia is present and sometimes the esotropia is not present, which is understandable because it completely relies on whether the child is accommodating or not, because fusional reserve is deteriorating slightly, slowly, gradually. They present more with asthenopic symptoms, and amblyopia in these conditions is more common, and there is poor binocularity as well. So I hope it is clear about what an acute accommodative esotropia usually presents with and what a refractive accommodative esotropia usually presents. Okay, now let's move on into a different category of acute acquired committant esotropia. This is a very interesting case. This was a 2-year-old male child that presented to a clinic with inward deviation noted since last 3 weeks. What was also quite significant was that there was a small amount of mild left-sided weakening. Left side of the body was slightly weak, and there was also a mild gait abnormality which was picked up when the child was walking into the clinic. Visual acuity was quite good. Cycloplegic refraction revealed just a plus 2.5 diopter sphere, which was not very significant in such a child. But because of the left-sided weakening and mild gait abnormality, we took this particular child, the evaluation of this particular child, more seriously. If you notice, there is a small angle, there is a 20% diopters of esotropia. And because of, as I said, associated neurological symptoms, we did the neuroimaging for this particular child. And here's what we came up with. There was a very large tumor in the posterior fossa. There was a large cerebellar pilocytic astrocytoma that was noted in the child, and that was causing an obstruction, and therefore a hydrocephalus was also seen. So this was a child that actually presented very acutely with esotropia and with a mild gait abnormality. Now, what was interesting here was that the gait abnormality and the left-sided weakness that was picked up in the clinic by the ophthalmologist was missed by the parents, because it was very mild and because there was nothing else that changed in the child's behavior. Subsequently, as you can see, the child underwent excision of the mass lesion. So obviously, esotropia was not the primary concern here, though the child had diplopia. Esotropia was not the primary condition. The child was referred to the neurosurgeon and underwent excision of the mass lesion along with a shunt. And when you see the child is presented after maybe around 8 months, there was still that persistent esotropia in this child. And after a couple of years, when everything in his neurological condition stabilized, the child also underwent extraocular muscle surgery, but still had an esotropia of close to around 16 to 18 prism diopters. Otherwise, the child is quite stable. Now, you see, this particular entity is also known as the neurological type of acute acquired committant esotropia. It's not very common, but it cannot be afforded to be missed. Now, this is an emergency. This is a condition that has to be picked up in the clinics. The pathogenesis of this condition is not really known, but maybe divergence insufficiency because of a tumor or because of an intracranial pathology is thought to be the reason. We will talk more about this particular entity later on during clinical evaluation as well. Moving on, there are some other types of acute acquired committant esotropia, and one of them is a decompensated type, where there is a phoria or there is a monofixation syndrome, but it remains a phoria till there is a triggering factor. In many cases, maybe a surgery or maybe an assault in different ways, and the phoria manifests into a tropia. So here also, when it is a decompensated phoria, it is a sudden presentation of such a condition. So this also is an entity which is very commonly seen in our clinics. Now, another type is this very interesting and a very rare type. If you see, this 4-year-old child had a normal birth and a developmental history, but had complaints of intermittent inward deviation noted since the last 2 months. Now, the father, when he brought the child to the clinic, actually said that there was a variable presentation, but there was no pattern that the father had noted. If you can see here, vision is good, but stereo acuity is poor. This was how the child was when he presented to the clinic. And we saw there was a large angle esotropia with poor stereo acuity, and he presented on this particular date. We had to call him back again. So when we saw him the next day, if you see, surprisingly, the child was orthotropic. And we did stereo acuity tests, and he actually had very good stereo acuity at this point. Even an artificial disruption of fusion and patching of the child did not disrupt fusion for them. He continued to remain orthotropic throughout the day. Subsequently, what we did was we asked the parents to document this on a daily basis. And we realized that the child was having a regular periodic presentation of esotropia and orthotropia. So the child would be esotropic on one day and orthotropic on the next day, and subsequently again esotropic on the third day. So this pattern was maintained consistently for around 6 weeks for this child before he went into a constant esotropia. Now, this particular entity constitutes cyclic acquired type of esotropia. It is a very rare condition, but it follows a regular clock mechanism. The most common rhythm that we see is a 48-hour cycle. Every 2 days, the child would be orthotropic, and then one day it will be esotropic. But otherwise, a 24-hour cycle, a 72-hour cycle, and even a 96-hour cycle has been reported. But what has been known is that the cyclic nature remains only for a certain period, and then it eventually breaks and converts to a constant esotropia. Now, it's a very fascinating kind of a condition, but what has to be known here is that the pathogenesis is actually not very clear. It is thought that maybe there is a non-compensatory component that is leading to esotropia manifestation, or maybe there is an incomplete cerebral dominancy, but the exact pathogenesis is still not known about this rare entity. And finally, we have come to the last case, which shows the last type of acute acquired committed esotropia. So this was a 10-year-old male child that presented with inward deviation since the last 2 months. And the significant history that the parents were giving was that the child was watching videos on his mobile phone for almost close to 7 hours daily. He had normal vision. His stereo acuity was still good. He hardly had any refractive error, but the history here is very significant. The child presented with a large angle, constant deviation, inward deviation for distance as well as for near. So this constitutes a very recent entity, a very recent type of acute acquired committed esotropia, but this is a condition that we see quite often in our clinics nowadays. And that is because of this. We are in a digital world. Everything involves use of phone or virtual screens. And we see that children are also beginning to use their smartphones and use their electronic devices. And this is the cause for this new entity, which is a new generation smartphone type of acute acquired committed esotropia. The principle of presentation is actually the same as that which was seen in uncorrected myopes, the Bielschowsky type, where we saw that there was persistent convergence because of prolonged near work. So what happens in a case of excessive smartphone use is that the child does not have any refractive error. The vision is good for the child, but because the smartphone or the screen is used at a very close distance, it inculcates the child to start using more of his accommodation and therefore convergence, and that leads to persistent convergence and increased tone of medial recti, and the same process kicks in. So what happens is that whenever a smartphone is used, it is very dynamic, it is very colorful. So there's a tendency to just keep the phone closer. Okay, so the working distance tends to reduce, sometimes less than 30, sometimes even less than 20. The other tendencies that patients with this kind of esotropia have is that they start using their smartphones very close, in the sense they use it when they are lying down, maybe lying down flat on their abdomen, where they start going closer to their screens, or even lying down on their back when holding the phone at the distance of 33 centimeters would be very difficult. So they hold it much closer. So basically the working distance reduces quite significantly. Also, it becomes very addictive. So without knowing, long hours of phone usage is seen. It is also known to be associated with other features like increased myopia, behavioral changes. So this is a condition that we are seeing quite often in our clinics. And I think inquiring about smartphone use, hours of use, and the distance at which the patient or the child uses the smartphone becomes very relevant in this condition. So with this, we have seen the different types of acute acquired committed esotropia, and we have understood about maybe what triggers each of these conditions, and therefore what questions we should ask specifically when such a case presents. Now, let's move on to see what else we have to evaluate when such a condition presents to our clinics. So apart from the complete workup, which is usually done for all such children, we have to stress on certain important aspects. So one is, as we just mentioned now, history taking has to be appropriate. It will give us a clue as to why this particular condition has happened. It will also give us an idea about how to start management in these cases. For example, if smartphone is thought to be the cause, maybe restricting the use of near work has to be the first step of management in such children. So appropriate history taking is important. Moving on, complete cycloplegic refraction is a must in most of these cases because you see many of these conditions present with a refractive error, maybe high myopia, maybe high hypermetropia. So refractive error has to be actually diagnosed. Maybe there is a latent amount of hypermetropia, which is making the child accommodate. So that has to be brought out in these conditions, and that can be done only by cycloplegic refraction. For cycloplegic refraction, we routinely use cyclopentolate, but in many cases, we also have to use atropine, which is a much stronger cycloplegic. But what most studies have said is that atropine additionally maybe brings out a hypermetropia of 0.34 to 0.5 diopters, in addition to what has been brought out by cyclopentolate. So there is just a maximum of 0.5 diopters of hypermetropia that has been noted in cases where atropine has been given. So even cyclopentolate is known to be a good enough cycloplegic agent unless there are clear signs that atropine has to be used. For example, if there is a very clear lag, or even after cyclopentolate, there is a reaction of the pupil or some such things. So in most cases, cyclopentolate is still good enough. Glasses prescription has to be given. And best corrected visual acuity has to be assessed after glasses prescription. So basically, as we all know, in children, the first visit of, when we give glasses, that does not really tell us what is the best corrected visual acuity. So we may have to call the child back for a second visit when we assess the best corrected visual acuity. And again, many of them may have amblyopia. So amblyopia therapy has to be started quite early in these patients. It is also important, as I said, to look at binocularity and the fusional vergence range. As we saw, there were many types where we saw that the fusional range was very, very less, very slim. So we'll have to look at that as well in orthoptic evaluation. Complete motor examination has to be done. A prism and cover test has to be done in lateral gazes, because not only in primary gaze, in lateral gazes as well, because if there is any incomitance, then it has to be brought out. Then maybe it is not even this condition. And even in vertical gazes, we'll have to see if there is a pattern, a V or an A pattern that is coming up. I'll come to why that is maybe more significant. We also have to look very closely whether the child has any nystagmus. So that is again a condition that has to be looked at very carefully in these patients because it is known to be associated with neurological type, which is an emergency in cases of AAC. And finally, fundus evaluation, it's done in every child, but here we have to be very careful in picking up maybe subtle signs of disc edema, papilledema, which is sometimes noted in cases of neurological type of AAC. So these few points should definitely be done in every case of acute acquired committant esotropia in our clinics. So now let's move on to a very interesting question, and let's see what the audience thinks. So should neuroimaging be done in all cases of acute acquired committant esotropia? So you can answer the question with yes or no, and maybe we can discuss it further. Okay, it is interesting because it's maybe an equal percentage says yes and no, but no seems to be higher. Okay, so let's see whether we are right or not. This is a dubious question, and that's why this doesn't have a very clear answer, but maybe I can make things slightly clearer. So when we are talking about neurological findings in cases of acute acquired committed esotropia, we already know it's quite a rare condition. And in this particular condition also, a neurological type of acute acquired is very rare. Review of literature states that neurological findings on MRI in such cases may be seen in about 6 to 30%. Now, this includes reports with quite small number of patients, but what has been reported is tumors of the cerebellum, brainstem, corpus callosum, sella, hypothalamus, and other associated neurological findings like Arnold-Chiari malformations, hydrocephalus, even cerebellar ataxia. In fact, Arnold-Chiari malformations are known to be quite commonly, they're one of the most common findings in cases with neurological type of acute acquired committed esotropia. Let me discuss this particular paper by Seth et al. Because it studied the largest number of acute acquired committed esotropia. It studied close to around 338 patients. And what they found was that 16% of patients actually had positive findings on MRI. Now, positive findings on MRI meant even incidental findings like periventricular leukomalacia and many other findings. But 13% of these actually had significant findings requiring neuro-ophthalmology consult. 22% of these 16% actually had an Arnold-Chiari malformation, which we all know needs an immediate neurological consultation. What was also very interesting was that all these 16% of the patients had the neurological examination was completely normal. So there was not any clear neurological sign or symptom that would have been picked up in these patients. And this paper also concluded that because there was lack of consistent predictive risk factors, it is always better to neuroimage in such cases. As I said, maybe this paper said that 1 out of every 6 patients came up with a significant finding on MRI. The numbers overall may be very less. But again, if it is a serious condition and if it is missed, then it cannot be excused. So till we maybe know more about clear risk factors that can tell us about a condition as being neurological type, it is always better to be on the safer side. Having said that, there are certain red flag signs, clinical signs that can point out to this being a neurological condition. And there are many studies that corroborate these. One of the most important ones is that neurological cases usually have an older age at onset. They usually present after 5 or 6 years of age. They have neurological signs and symptoms in many cases. So if such a sign or symptom is present in your patient, then you have to neuroimage. Usually, neurological type of acute acquired do not have an accommodative component. And again, a very significant, important finding in these is that there is a larger angle of deviation for distance than near. So there is a near distance disparity. Esotropia is more for distance and significantly more than 40% is the difference that is noted. This is again a very significant, important finding. Some reports also say that there's a small pattern, usually a V pattern that is noted in such cases with an oblique muscle overaction. So that is why I had said that in prism cover test in motor examination, you have to even check for up and down gaze to bring up this particular pattern. Most cases have poor fusion and poor binocularity. There is an associated nystagmus. Very commonly, there may be an abducting nystagmus or an asymmetric optokinetic nystagmus. And also, they may have recurrence of esotropia. So if you see a recurrent esotropia coming up, then it is important that you rule out this neurological type. I hope it is clear about how we evaluate such cases when they come to the clinic. Let's briefly touch upon management of these cases. So once we diagnose this case that comes to the clinic as acute acquired committed esotropia, how do we think about managing? So this is a rough protocol. We usually follow this pattern. Okay, so first we'll have to do a complete cycloplegic refraction in the first sitting. We'll have to give glasses if it is required. We have to start amblyopia therapy. So that is the first thing that we do in such cases. Subsequently, when we give, we'll have to call them back for a follow-up and maybe start orthoptic exercises quite early in these patients. Now, as I said, most of these cases are acute onset. So usually they present to the clinic also quite fast. So as an interim, maybe after giving glasses, we'll have to start them on orthoptic therapy, which includes both prism glasses as well as fusional divergence exercises, which I'll be talking about subsequently. But as we saw, many of these conditions have very poor fusional reserve. Therefore, it is important to start orthoptic therapy quite early in most cases. Subsequently, one option is Botox injection, and that is an option only because it can be done intermittent. It can be done as an intermittent form of treatment before we think of a permanent solution. It is known to be quite effective, and you can give an injection Botox and also continue with the orthoptic exercises. So that is an option which doesn't have to be done in every patient, but it is definitely something that has to be offered to the patient quite early on. Sometimes it is also important if the child is young in an amblyogenic age group where we know that maybe the child will go into amblyopia if not treated immediately. That's again one of the indications where we can give Botox injection, because orthoptic exercises may not be a feasible option in very young children. But what has to be clearly understood is, as I said, presentation is quite early and it may even be variable. So multiple visits to the hospital is required, and at each visit, we need to take new measurements. So multiple measurements will have to be taken. It has to be taken over a period of maybe 6 to 8 months sometime. And it's very important that we do a prism adaptation test in all these patients, basically because, again, as I said, it all depends on the fusional reserve. So if the patient has a fusional reserve, maybe the patient will be trying to fuse, and maybe the entire amount of deviation that the patient actually has is not manifested in one visit. So a prism adaptation test has to be done in almost every case. Finally, after 6 to 8 months, waiting for a minimum of 6 to 8 months, if there is a consistent angle, then we can plan for an extraocular muscle surgery. And it's always best to operate on the largest angle that has been found, and it is usually the one that comes up after PAT. So this is usually the sequence of management protocol that we follow in the clinics. And let me touch upon a few aspects here. So orthoptic exercises or orthoptics, when do we use it? So there is no clear evidence to show that vision therapy helps in divergence insufficiency. It is very clearly documented. It helps very nicely in convergence insufficiency, but in divergence insufficiency, we are still not very clear. So the best therapy, if we have to give orthoptic therapy for them, would be to try on Fresnel prism and maybe give additional vision therapy, maybe in the form of vision therapy system or Brock string exercises. This is the principle behind that. So this is an interesting case which presented with a large angle acute esotropia, acute acquired esotropia, and was given a Fresnel prism. The prism was given for an angle that was actually 45 prism diopters. And the idea is that we bring the eyes within the fusional range and then slowly wean away the prisms. So in the subsequent visit, after 3 months, the patient was seen to have a slightly lesser amount of esotropia without the prism glasses. And after close to around 6 months, he had a much lesser angle, almost close to 18 prism diopters of esotropia. So this particular case responded very well with Fresnel prism and fusional divergence exercises, but we still don't have enough evidence to say that it works in every case. And we also do not have enough evidence to very clearly indicate as to what cases and for how long we give such treatments. But this is an option that has been tried, and it has been reported in literature as well. The other option, as I had said, was giving injection Botox. It's a feasible option, especially it can be given early. Reports have suggested good motor success rates, but the only side effect or the only problem with Botox injection is that the first injection usually gives resolution on only 50% of the cases, and subsequent injections, maybe 2 to 3 injections, have to be given in the patient. So as you can see, this child presented with a large angle esotropia, was given injection Botox, but this particular photograph was taken only 2 days after the injection. So obviously the child had maybe an exotropia. The same child after maybe 1 month or 6 weeks may go back into an esotropia. But results are variable. That is the disadvantage of this, but it is definitely a feasible option. And finally, we have the option of surgery. Surgery for esotropia can be either unilateral medial rectus recession, bilateral medial rectus recession, maybe a unilateral medial rectus recession with a lateral rectus resection, or even a 3-muscle surgery. It all depends on the amount of deviation that the child presents with. Some studies have reported just a standard surgical dose according to Park's table. They've said that that should suffice, but some studies have said that an augmented surgical dose is required because post-surgery, there has been known to have some residual esotropia, but there are no consistent findings. So if this was just a very brief review and looking at the first column where Seth et al. Studied the maximum number of patients, they said that following standard surgical dose would give good motor outcome in close to 71% of the patients. The rest of the studies actually had much less sample size. So, but still, probably surgical correction would give a good and reasonable motor outcome in most cases. But there are certain predictive factors which can give better results. So it has been noted in different papers that there is better prognosis if there is significant hypermetropia, if there is family history of strabismus. Usually there's a smaller angle of deviation. Now that is, the logic behind that is probably because binocularity may still be maintained. Again, early presentation after onset is a good prognosticating factor, maybe because again, binocularity is maintained, mild or no amblyopia can give good results. So to summarize, whenever we see a case of acute acquired committed esotropia, we have to ask relevant questions in history. We have to sometimes revisit history. It can give us clues as to what this condition could be and therefore give a direction to the management of such a case. A new entity, increasing smartphone use cannot be neglected. It has to be looked at very seriously, and maybe further studies have to be done as to how this actually, and come up with a protocol as to how much of smartphone use is actually can be allowed in such children. Complete cycloplegic refraction is a must because the refractive accommodative element must be tackled initially. Multiple measurements and prism adaptation test is essential before we think of final treatment, and watch out for red flag signs in cases of acute acquired committed esotropia. Definitely such cases have to be imaged. Thank you. I'll start with the first question that has been asked. So does in Swan type one eye always have less vision and poor fusion and binocularity? Because of that leads to deviation with monocular occlusion? And can these patients have good vision in both eyes? So thanks for the question. So basically here, it is not a rule that it has to have a uniocular amblyopia or poor binocularity, but most cases, patching is started in these cases because of such an underlying condition. Because it has happened that the child has been patching in one eye, that esotropia manifests. So there is no rule. It has, as I said, it has even been known in cases where the eye has been patched for maybe 2 or 3 days because of a corneal condition or maybe because of mechanical ptosis. So even in such cases, even with good vision in both eyes, this particular condition can result. And the pathogenesis has got nothing to do with vision here. The pathogenesis is mainly the fusional reserve and the disruption of fusion that happens. So it can actually have good vision in both eyes as well. All right. So the next question is for acute committant neurological esotropia. Why not because of sixth nerve palsy? I'm not sure I understand this question rightly, but maybe what you want to know is that maybe there's a sixth nerve palsy and not a committant esotropia actually. So that's a very good question, because sometimes, as I said, an acute incommittant esotropia or a very small amount of sixth nerve palsy can look like a committant esotropia. So a very clear examination has to be done. Sometimes it can be missed, and that is why we have to maybe have a very good fundus examination, and that is why we cannot miss imaging such patients. Various reports in literature have actually reported a slight amount of incomitance, close to maybe half abduction limitation in cases of acute acquired committant esotropia. So they have misdiagnosed it, or maybe it's a part of this as a sixth nerve palsy. But it could very well be, but this can be brought out by a very thorough clinical evaluation. Moving on to the next question. Should we perform neuroimaging in all cases of acute acquired committant esotropia? As I said, there is a lot of, this is a gray area, a lot of confusion, but what most studies say, especially the study which looked at the maximum cases of acute acquired esotropia, it said that 1 out of every 6 patients of acute acquired esotropia actually had a significant intracranial pathology. And if that is the case, then I think it is better that we neuroimage, at least as per our knowledge at this level. Because if subsequently we are able to very clearly find out what the predictive risk factors are for neurological type, then maybe we can come up with a better screening method. But till then, it's always better to neuroimage. At least that's what I do. So another interesting question as to what is the vulnerable age range of children for acquired esotropia due to excessive smartphone use. So that is again an interesting question. There is no right answer here. There is no study that has proven that this is a vulnerable age. We are seeing children, younger and younger children, actually coming into the vulnerable age. The only factor here is that how well is the binocularity developed, or how well the fusion has developed in such a child. And actually it develops at a quite young age. So I don't think there is any particular age where the child is more vulnerable or there is a higher chance of esotropia manifesting. But I think there are other factors like the amount of hours of smartphone use and at the distance of smartphone use that become more relevant here. So that is what I would think are more relevant, but this is what is the knowledge as of now. So the next question says, what is a recommended distance, not only for smartphones? Yeah, so as I said, near work has to be around, usually it's around 33 centimeters, so it has to be beyond that. So anything close to 33 centimeters should be okay, but even that should never have a prolonged near work. It's always advised, as you see, even in myopia management, it is advised that we take a break. And that's where the 20-20-20 rule came, that every 20 minutes you have to take a break. And I think that is more important, but definitely nothing less than 30 centimeters. That would be the distance that is required. All right, so moving on to the next question. Do myopic presbyopes who do not wear reading glasses with sudden esotropia fall into the category of Bielschowsky? That's a very nice question. In fact, the article by Bielschowsky about this particular condition when it was first published actually mentioned this category as well. So they said that because they are uncorrected and because they use their accommodation more, they come into the category of Bielschowsky. So that is correct. They do actually. Moving on to the next question. At what age does amblyopia occur and how does it affect permanent mechanism of vision? So again, there are multiple factors that are involved here, because we all know that generally amblyopia can occur before the age of 7, 8, maybe 9 years. That's also not a clear demarcation, but generally that is considered to be the level. But if you're talking about amblyopia in connection with acute acquired committant esotropia, well, since it's acute, again, maybe presentation, if it is early enough, maybe amblyopia would not have set in. Again, it depends on the amount of deviation, maybe it depends on the amount of time between onset and presentation, and it depends on every child actually individually. So we cannot tell at what age it occurs, but then again, if it comes within the amblyogenic age group, then yes, then it does set in. And about how it can affect permanent vision, well, that's why amblyopia therapy has to be started first. So amblyopia is reversible, and it is seen that, and if you see in the management protocol, I had put amblyopia therapy as one of the initial steps. So it has to be started as soon as possible, and it can be reversed. So it may or may not improve. And so the factors that I mentioned before are important in actually understanding the depth of amblyopia. So it all depends on that. And I hope the answer is clear. The next question is, which cases do you consider doing atropine refraction before planning for squint surgery? As I said, there was a comparison between atropine and cyclopentolate. In many cases, cyclopentolate has proven to be good enough. But in cases, again, as I said, there's a lag. Post-dilation, there is maybe, maybe the cycloplegic refraction has not been done exactly 45 minutes after cyclopentolate. So the pupil is constricting, and if the child is still accommodating, or if you find variable angles in subsequent visits, then definitely you consider trying to use atropine. So that's what I do in the practice. But cyclopentolate, if everything else is okay, cyclopentolate is known to be good enough. So again, you have brought out that atropine brings up sometimes close to 2 diopters or greater. And yeah, definitely. As I said, we'll have to be very thorough in our clinical examination before saying that cyclopentolate is good enough. So if there are signs that there is still a little bit of accommodation happening, definitely use atropine. Now, having said that, in our clinics, sometimes it becomes very difficult to do a cycloplegic refraction exactly 45 minutes after cyclopentolate. It also becomes very difficult for us to analyze the subtle changes that can be actually seen, that accommodation is still persisting after cycloplegic refraction, after cyclopentolate. So to be on the safer side, we do use atropine, but if done correctly, then cyclopentolate is known to be good enough. So one of the questions is that one of the factors for amblyopia is deprivation. And can I explain? So, so basically, deprivation is definitely there. It's actually not called deprivation. So the type of amblyopia in such children, most, because if it is because of strabismus, is strabismic amblyopia. So because of strabismus, one of the eyes, the child prefers to see with one eye, and the other eye goes into a state of deviation, either inward or outward. And because the one of the eyes is deviated, that eye does not have its vision developing equally. So that is what happens in such cases of strabismic amblyopia. And as I said, maybe children start focusing on one eye, they start preferring one eye, and the other eye goes into amblyopia, and that eye usually manifests the deviation. So this is a form of strabismic amblyopia. The next question is that, so can accommodative spasm be associated with Bielschowsky type of esotropia due to excessive near work, like smartphone usage or other digital gadgets? So that is a very good question, because that condition of accommodative spasm can actually be confused with Bielschowsky type, where on dry refraction, both will come up with a myopic finding. But the difference here is that post-cycloplegia, accommodative spasm usually will have a much lesser myopia, sometimes even a hypermetropia. That will not be seen in a case of Bielschowsky. Apart from that, there will be maybe sometimes a meiosis that can be seen in accommodative spasm. So these are the ones that can differentiate accommodative spasm from Bielschowsky type. But that's why it's important to understand these types, understand the pathogenesis. That's when we'll be able to differentiate one from the other. But it is not the same as Bielschowsky type. All right. So the next question is about Botox injection, and for how long do we give Botox injection, as its effect lasts only for 3 to 4 months. So as regards this question, yes, Botox, the effect is known to be variable, results are known to be variable, but in strabismus, Botox has, you can go through literature, it says that Botox actually can cause even permanent recovery. And it has got something to do with a change that happens in the anatomy of the muscle because of Botox injections. So it is even known to cause permanent improvement, but again, it is variable. And as you say, it can recur, but it can even lead to good results. And if your question is also about how long we keep giving, so literature reports maybe around 2 or 3 injections are known to give an equal result as 1 surgery. So those are the statistics, and I think it depends on an individual practitioner. Okay, so one question is prism in right eye or left eye. So that depends mostly. It all depends, because it depends on the vision, it depends on the patient comfort. So I think that would basically be clear only after an orthoptic evaluation. So the next question is, what do you do if the cyclo gives a higher power like -6? As I said, that will probably come under the category of Bielschowsky type. We'll have to give them the refractive error. Usually, patients do not have a problem accepting myopic correction. So it's not like in hypermetropia where they may have to get used to it. So it might not be a very difficult thing for the patient to adapt. So we go right ahead and give that -6 diopters. One of you has shared about your experience, and it says that surgery works very well and not Botox, but stereopsis does not recover as well as deviation. And yeah, so a lot depends on the point that I had discussed about predictive outcomes. So better results were found if the time between the onset of esotropia and presentation to the hospital was lesser. So basically, it was a shorter duration that the patient actually had esotropia. And if we start our management, start our treatment early, it is known to actually preserve binocularity. So this was the very significant predictive factor that was described. There was another paper which told about the predictive factors of Botox and said that if it's a smaller angle and if there is good binocularity already in the patient, then that also gives good results. So it actually depends on the profile of the patient that presents to you. in the and I shown in the paper by Seth et al., where they had studied the maximum number of patients, it resulted in only 71% of good good motor outcome. Basically, that meant that there was this 30% which did not have good binocular vision or even good motor outcome, and that was because of the slightly late presentation, amblyopia already setting in, or poor binocularity and loss of fusion. So yeah, so it all depends on the patient profile that comes to you. I'll probably leave this question about how do we do PAT for maybe some other time, because it involves a lot of orthoptics where prisms have to be given on a trial frame, and the patient is asked to wear them for a continued period of time. There are different papers as to what time is actually suitable. Some say 20 minutes and some say close to 1 or 2 days, sometimes even weeks. So it's a completely different topic. So, but yeah, it's got a lot in it, and it's very important to do a thorough PAT in such cases. So the next question would be that, do you think some sudden onset esotropia will converge to the blind spot? So I'm not sure what is the point that you exactly want to ask me, but maybe it is that at one angle where the fovea now starts focusing is if it falls in the blind spot. Is it like maybe something like 15 degree? Well, if it actually comes there, then obviously the brain and eye coordination will see to it that the eye focuses at a slightly different angle. Okay, so I mean, I think if that's your question, then there will be a slight difference, because the brain is constantly working and it tries to fuse to as reasonable an angle as possible. One question says, how many types would you consider of acute acquired accommodative esotropia? So I showed you close to 7 types. So these types have been evolving with time. As I said, initially there were only 3 types that was described in literature, and now we have 7, maybe the 8th type, which includes a smartphone type. So things are evolving in acquired esotropia, and we have to look at all these types because each one has a different pathogenesis. I'll move on to probably just 1 or 2 questions more, but how can we, why exactly is Botox given in acute acquired esotropia? So the indications there will be, these are not discussed completely in the talk, and therefore I'd like to discuss it now. But as I said, if it's a younger child in the amblyogenic age group where maybe there is no significant refractive error, but the child has an esotropia, may go into amblyopia, and you want to reduce that quickly. You can't wait for 6 to 8 months till you decide on surgery. So that's probably one of the reasons, one of the cases where you give a Botox injection. It can also be given, for example, in a very large angle esotropia, say 75 or 80, to bring down the angle of esotropia and then start the patient on orthoptic exercises for better fusional reserve. So it's difficult to start the patient on orthoptic exercises if the patient has close to 70 prism diopters of esotropia, but an injection of injection Botox can bring down the angle and help. So these are some of the specific indications apart from the other indications of Botox in these cases. And this question about what's the percentage of surgery that is successful, and if that is the only option. So as I'd shown the table before, the paper with the largest number of patients showed a surgical success rate of 71%. Other reports also have been telling about a surgical success rate of around 65 to 75%. But yeah, so it's a good success, good rate of success if surgery is the only option. All right, then I think maybe we can end today's webinar. I thank everyone for joining and participating in today's discussion. Thank you very much. I hope this has given an insight into acquired esotropia to all of you. Thank you very much.